A gentleman who has done a tremendous amount of work in looking at free markets, and he's a scholar at the Mercatus Center at the George Mason University, and they do some of the most important work in terms of free medicine and certificate of need and healthcare IT, which I think is what Dr. Robert Graboyes is going to concentrate on tonight. So without any further ado, please let's have a round of applause for Dr. Robert Graboyes.
Thanks, Bud. Well, good evening, Irving. Delighted to be here. Thank you so much for having me. I have to tell you, this has been an incredible conference. I've been thoroughly enjoying listening to the speakers, which included some old friends and some new friends as well. So it's been a pleasure. Just a little introductory information. So I'm calling this talk Fortress and Frontier in American Healthcare. That's the title of a paper, a study, an ebook. You can get it on Amazon Kindle, or you can download it on PDF off of the Mercatus website. I'm Bob Graboyes. Title is Senior Research Fellow. I'm an economist at the Mercatus Center. And you've got a couple of bits of other vital information. I assume that we can make this available to folks. Great. So we'll have this available to you because there's some information you might find useful to have as a reference afterward. There's my email address. That is not there in perfunctory manner. That's there because it's an invite. If you've got ideas, if you've got suggestions, please write me. Glad to hear from you. That's why I'm here. And at the bottom there is my Twitter handle. I am very active on Twitter. I love to broadcast things about innovation in the sphere of healthcare, in innovation in other things. And I don't know, I'm a pretty funny guy, so I also tweet some pretty amusing things that may have nothing whatsoever to do with it. Yesterday I was tweeting on Bob Dylan getting the Nobel Prize in Literature, so I was pretty happy about that, actually. So let's see. So this is the cover of the paper that I did about 2 years ago, and it's sort of the center of my studies. I called it Fortress and Frontier in American Healthcare. Again, it was published by the Mercatus Center. It is available on Kindle for some very small price. And again, it's for free on our website. So what's this about? My argument in it is that there's a divide in the way we view healthcare in America, and it is not a left and right, Democrat and Republican, liberal and conservative divide. My argument is that both sides of the political spectrum are way more similar than either of them would like to admit. That both of them see healthcare, they have what I call the fortress viewpoint. Fortress viewpoint says that public policy, law and regulation, custom in healthcare has two major purposes. One is to imagine every terrible thing that could happen to any patient in the course of healthcare, and to throw all the vast resources of the country at trying to prevent anything bad from happening. So extreme risk aversion. And the second purpose of public policy, which is kind of parallel, is to protect insiders from outside competition. Insiders can be people in this room, physicians, it can be hospitals, it can be insurers, drug manufacturers, device manufacturers, you name it. But it is a sense, dare I say, a sense of entitlement that says they've worked very hard to get this way, and we don't want anyone challenging this. Hospital is our big employer in this town. We don't want other people moving in and opening a better hospital. We don't want doctors to be challenged by nurse practitioners or telemedicine or direct primary care or what have you. On the other side, we have the frontier. The frontier is a very different viewpoint. The frontier says public policy, it's a worldview that accepts the fact that if you want innovation, if you want progress, if you want change, if you want improvement, You have to let people take risks. We didn't get medicine the way we have it now because no one ever died in the course of experimental treatments. People were allowed to take calculated risks. There were conversations between patients and doctors. And I'll give you a few specific examples. And also, it says that if you really want innovation, everyone in the business, be it hospitals or insurers or drug manufacturers or device manufacturers or the people sitting in this room, need to face competition. Competition that, quite frankly, could put you out of business. It's what other industries face. And the absolute ultimate frontier industry in this country, in at least the last 25 years, has been information technology, has been solidly out there on the frontier because of legislation. One of the most remarkable legislative achievements in my lifetime was, and it's very much underwritten, somebody could write a great book about it, around 1990-91, both sides in Congress stepped back and said, we've got these new technologies coming along, this thing that's the internet that's been kind of a closed system among the Defense Department and universities, and we're going to open it up. And we're going to let people experiment. We're going to let people commercialize it. Before that, it was forbidden to send a personal message on the internet. You couldn't send any commercial message because you'd be in violation of federal regulations on it. Congress stepped back and said, let's let people experiment. And yeah, there'll be problems along the way, but you know what? We'll fix them as we go rather than trying to prevent every little thing beforehand. Now, people often look at me after I've made this statement and said, you're talking about two different things, apples and oranges. Medicine, it's all about life and death. It's all about sickness and pain. It's your health. Information is just a cell phone sitting there on this podium, or a laptop, or whatever else it is you're going to type during my talk. And I'll say no. Actually, I will contend that the information technology that we carry around in our pockets, our phones, our iPads, our laptops, whatever, can inflict as much, maybe more damage to human life, to safety, to health, than anything any doctor in this room could possibly do in a lifetime of malpractice. If you think about it, 15 years ago, the World Trade Center came down. It would not have been possible without the coordination of cell phones. Someone who was frightened to death of information technology in 1990 could have said, I don't like this. I don't like cell phones. We'll get terrorism. We'll get fraud. We'll get gigantic theft in ways we've never imagined. We'll have foreign governments messing in U.S. finances and elections and whatever. You'll have reputations ruined. And every one of these worries would have been correct. But we didn't stop it. Congress somehow said, yeah, these problems are going to happen. Let's deal with them one by one as they happen rather than stopping the world out of deadly fear of it. And it really was a remarkable moment in American legislative history, and I don't even understand how it happened. And I think it's something that's worth thinking of. But what I would like to see is a shift more toward the frontier in medicine. And we'll talk a little bit about what that means. So what I'm really getting at is to get out of the quandary we're in. Escalating costs, quality, spotty quality in American healthcare, inadequate coverage in some areas. The only way we're actually going to solve these problems is the same way that we solve problems in IT. I'm holding in my hand here an iPhone 6. This is more powerful than any computer that the CIA owned in the 1980s when I started out in economics. It would have cost vast amounts. The computing power in this phone would have cost around 1960 or thereabouts, would have cost about, in theory, $100 trillion in today's money. Today, I got it for a couple $100. Some of the other speakers today talked about that. And the question is, how did we get there? We got there because of the frontier mentality, not staying on the fortress. So what do we mean by innovation in healthcare? When people talk about innovation in healthcare, they tend to think of this. There's the National Institutes of Health, just outside of Washington. And I don't mean to criticize the NIH. I often will say that very likely the NIH you could argue that it is the single most successful federal agency, most efficient. It does wonderful work. I have the highest opinion of the people who work there and the work that they do. But the notion here is that innovation means we're going to throw a couple of tens of billions of dollars and cure Alzheimer's, cure cancer. We're going to do some gigantic things. We're going to, when I talk to people on the Hill about policy, and this would be liberals or conservatives, they tend to say, yes, we need more innovation, so therefore, federal government is going to throw several tens of billions of dollars and make really cool electronic medical records. And we need them to work, so we'll tell everyone they got to use them. Well, innovation, that's one kind of innovation, and I'm not opposed to it. I often say the government is actually quite good at certain kinds of innovation, and I'll often cite the Manhattan Project to develop the bomb, the space program to get to the moon and back. Governments had a major role in the eradication of smallpox. The Defense Department created the internet before it turned it loose on society. And the Human Genome Project were all government efforts, at least in part. And they worked magnificently well. And I will argue that the government has a terrific role when a couple of conditions hold. When the science is already known, it's just an engineering problem. And secondly, when you can say definitively, in retrospect, did it work or didn't it? Did the bomb go off? Yes, it did. Did we go to the moon and back? Unless you're a little bit odd, yeah, we did that too. And did the internet work? Magnificently. And so forth. And the third condition is you have to not care very much how much it costs. So if those conditions hold, this sort of innovation works great. But I'm of the belief that an awful lot of what will drive 21st century innovation is going to look very, very different. It's going to look a lot more like what you saw in the last 25 years in IT. We did not have the Federal Department of Apps developing the hundreds of thousands of apps that appear on your iPhones and your iPads and other devices. Facebook was not a federal project. We do not have the Secretary of Twitter. Healthcare innovation looks more like the things these people do. So, first of all, a quiz mostly will designate your age. Who's the person on the left? Hedy Lamarr. Headley, yes, Headley. Okay, does anyone know why I'm showing Hedy Lamarr? She wasn't a spy, but here was the interesting thing. Hedy Lamarr was an actress in Europe in the 30s, in America in the 40s, and a little bit in the 50s, and her star somewhat faded after that. She was considered the most beautiful woman in Europe. She was married in Europe to a piece of scum who was an arms dealer, who was an enthusiastic dealer to the Nazis during their rise. One of the things her husband did was he liked people to see who he had married. So he dragged her from meeting to meeting and told her to just be quiet. So she was quiet but listened. When she fled him and fled the Nazis and came to the US and became a star here, it came to her attention that the Nazis were jamming U.S. radio-controlled torpedoes, rendering them useless. And she thought about it, and unbeknownst to her husband, she had become a world-class arms expert of high-tech arms. And so she envisioned, I know how to stop the Nazis from jamming torpedoes. She didn't know how to build it, so she went to a friend of hers who was a composer and a conductor, and he said, well, you know, years ago, back in the 20s, I wrote an opera that required 18 pianos on stage synchronized perfectly, and they used piano rolls. Why don't we just use a piano roll in the torpedo and one in the radio, changing the frequency back and forth so the Nazis can never find it? It wasn't used in World War II, but it was used to stop the Soviets jamming our broadcasts during the Cuban Missile Crisis in '62, and ultimately it became the forerunner of Wi-Fi and Bluetooth. The remarkable thing here is that she's not someone you would have expected, a Hollywood actress, to be this genius inventor. You won't know the people on the right. The two brothers there, the one on the left grew up with my mother, and he was our family's doctor for decades, for, I don't know, close to 70 years he was the family's doctor. And one day my father told me, you know, basically Milton, that's the doctor on the left, said, you know, basically he kind of invented the idea of stem cell therapy. And I thought Dad was just kind of exaggerating a bit, until Scientific American some years later acknowledged that he had indeed been a pioneer. In a tiny little hospital in Petersburg, Virginia, he had performed the world's first stem cell transplants to fight cancer. And in the early 60s, when he had this epiphany that maybe there was something in infant blood that would restrain the growth of cancer, you could do that sort of experimentation. Today, the protocols of experimentation would, your institutional review board would take forever if it ever even allowed it. And even then, because he was a nobody, he couldn't get funding and never could get published, and it took 40 years for the world to acknowledge that he had done a really remarkable thing. And that's his brother, who's still around, and is a pathologist who assisted him in the research. The bottom picture is a little girl named Shay. Shay was born without fingers on her right hand. 3 years ago, if you wanted to buy Shay a prosthetic that would allow her to pick up a glass of water or ride a bike, the minimum would have been about $5,000. Until a carpenter in South Africa accidentally sliced off his fingers. Couldn't afford prosthetics, and the doctor said, the way you've sliced them, prosthetics aren't going to work very well anyway. So he emailed a fellow who's become a friend of mine, saw him last week, Ivan Owen, a puppet maker in Washington State. And he sent these pictures of this mangled hand saying, I've seen the hands you build for puppets. Is there anything you can do for me? And Ivan said, let's work on it. And by Skype and email, they developed a 3D printed hand that you see with Shay. And that hand probably cost something on the order of between $30 and $50. And there became a whole wide world network of people building these prosthetic hands for children and others in need. And it essentially reduced by 99%, like that, the cost of a workable prosthetic hand. And I can go on all day about innovations like this that are occurring now, although there are serious restraints on them. So I was talking to the inventor of this, had lunch with him a week or two ago, and he and his wife said, you know, the interesting thing is the real innovation in this is moving to Colombia and Paraguay. Why would you guess the innovation is moving to Colombia and Paraguay? Yeah, I mean, the FDA has been okay. They've You cannot talk about these without a pun here and there. They've had a hands-off attitude on the building of these things, but within restraints. If you try to sell them, if you try to motorize them, if you attach sensors, suddenly it will become an FDA-covered device and impossible. These two countries have said, you know what, we don't have the resources to bother you, so why don't you do it here? And all sorts of miraculous innovations are coming out in these countries. So, one more. President Obama assigned Vice President Biden to head up a cancer moonshot to try to find the cure for cancer and gave $1 billion to the effort. I will say it's a noble effort, and particularly given the tragedies that Vice President Biden has had in his own family. But I'll also note that it would cost $1 billion to come up with a new analgesic. If you wanted a variety of aspirin, it would cost $1.5 billion probably to bring it. You're not going to cure cancer. So I wrote an article co-authored with Tom Stossel, a cancer researcher at Harvard. You may know his brother, John Stossel, the journalist. And what we said is, curing cancer is not like a moonshot. It's not JFK saying, here, we know the science, it's an engineering project, and we don't care about the money, let's just do it. It's much more like, interestingly, one of the best policies, in my view, that's come out of the Obama administration, which is commercial space policy, which has basically said, federal government's going to step away from launching rockets, and we're going to encourage 50 or 60 companies out there to fight each other over how to do it best. And you're getting all these wonderful different innovations in space flight. And so we argued this is the model that the federal government ought to be looking at rather than the moonshot attempt, which, again, we think is sort of noble, but probably isn't going to work. Now, let me get to an innovation that's of interest to me personally. So I have a little device here on my cell phone. You probably can't see it. I'll show you a picture in a minute. So I gave a talk in Phoenix in April about that device. It's a device that can do an EKG, I guess it's a 1 lead or 2 lead, I forget. But it'll do, it's FDA approved, it's clinical quality. And I spoke to a group about this size, 250 insurance administrators, and said, how many of you have heard of this? I don't think anyone in the room had. I said, you realize if you have a patient who's one of your subscribers with atrial fibrillation, you give one of these things, you can prevent who knows how many unnecessary visits to the ER when they hold this thing for 30 seconds and it says, no, you are not having AFib. Or you might prevent one of your subscribers from having a killer or non-killer stroke when it says, yes, indeed, you better get to the ER. The wording's a little bit more subtle than that, but that's basically what the message is. So I flew home from Phoenix. The next morning, I woke up around 6 a.m., and for the first time in my life, I felt my heart going, and I sort of, and I said to my wife, something's going on here, I think you better get me to the ER. And I went to the ER, and indeed, one day after giving this talk, I was in atrial fibrillation. And anyway, just for what it's worth, they did every test in the book, and there was not a physiological thing wrong, from CAT scan, whatever, so I don't need any Coumadin or whatever. I'm hoping it's a lone wolf, but we shall see. 6 months this week, and I haven't had a recurrence. But there were a couple times I didn't know if I was having a recurrence. So about 10 or 11 days into this, after this, they had put me on metoprolol, and then they said, my cardiologist said, stop it for 2 days because I want to do a treadmill test, and it's not going to work if you take it. So I stopped it. And I was sitting there playing piano at home at 7 p.m. after dinner, and I started feeling it speeding. And I said, and I was at this point, it was early in this, and I was still a little panicky. I said to my wife, I think you better take me over again. So they hooked me up. They said, a little tachycardia. You've gone up from 50 or 60 to about 100, but it's perfect sinus rhythm, so no, there's no problem. You can go home. And I thought, well, that's good. I feel reassured, and somebody just spent $3,000 to reassure me. That was this visit. It was evening. So I darkened it a little bit. Now, for giving talks like this, I had been meaning, even before I had AFib, I wanted to buy one of these things just to demonstrate it when I give talks like this. So I bought it, it arrived, I gave a talk to another group like this up in the wilds of western Pennsylvania. I finished my talk, hopped in my car, and I was driving on this road. And let me tell you, after driving on it, what you're seeing here is a heavy day of traffic on that road. As I'm driving along, and I was on my medications, everything was as calm as could be. There was certainly no stress on this drive. It was a beautiful time. I started feeling my heartbeat accelerating. And I started getting worried because I was probably 15 to 20 miles from the nearest significant town. There were no cars on the road. And I was thinking, what if something's happening to me out here? And again, this was still early. I'm a lot calmer these days since I've had 6 months to think about this and figure out my patterns. But fortunately, I'd bought 2 devices. I bought this Fitbit, and as I was driving, I could do this every 15, 20 seconds and see, yep, 50, 55, 60, 63, whatever. And it went up to 118. And I was getting pretty scared. And I pulled into, there was fortunately a gas station. I pulled in. Oh, here's my Fitbit. And by the way, that is from that evening, June 3rd. I can pull up any day in the last 4 or 5 months and show you the whole course of my heartbeat. You can see about 7 o'clock p.m. where it went up there for no apparent reason, where I was getting worried. And I pulled into a service station, and I took out my AliveCore, a product built, by the way, invented up in Oklahoma City. It seems to be something about that town that does a lot of good stuff. So I took it out, sat there. When I took it, I produced this, again from that night, 7:57 p.m., June 3rd, 2016, 97 beats per minute, perfect sinus rhythm. I looked and said, I guess I'm okay. I walked around a little. I think I took one more and said, I guess I can get back on the road. And I thought, I probably just saved, at the end of the year, when you add up how much we spent on American health care in 2016, I probably just cut it by $2,000 or $3,000 because I didn't go to the ER. I'm not sure I would have, but I might have. And I calmed myself. And I didn't have to spend any money on a hotel. I didn't have to ruin my trip home and arrive a day late. It was just, it was magnificent. And I just, I don't like having the condition, but I said, if I had to get a condition, this is the one to get because I can show it off all over the place. So anyway, so I'm now 6 months and nothing's ever happened and I'm fine. And there are lots of other innovations. 23andMe. Just show hands as I go through these. How many of you are familiar with the story of 23andMe? Okay, I would say half. So 23andMe, wife of one of the Google founders. This is a DNA test. It was $99. Spit in a little bag, mail it to them. They would send you back 250 readings of your genetics and tell you, yeah, it looks like you might be prone to alcoholism or obesity or cystic fibrosis or this, or it would sort of tell you how to manage your health. And the FDA swooped in and said, you can't do this here. You can get people to spit in the bag and tell them who they're related to. You can use it for genealogy, but you are forbidden to use it The company was forbidden to provide any information on how you analyze the genetic readings. If you want, you can go to Britain and do it. They're fine with it. Plenty of other countries you can use it, but not here where it was invented. This is alternative. I wear eyeglasses. I have been for a long time. They're pretty expensive. Alternative, how many have heard of this? Not very many. Alternative, you take your laptop and your smartphone, and you stand there, and it says walk backwards, stop, cover your right eye, read the top line, X, D, L, F, whatever. Okay, cover your left eye. Now walk back, whatever, stop. It's sensing how far back you are. And this is all free. And it will analyze, it will write a prescription, it will figure, I forget what that's called, how far apart how far apart they are. And the next morning, an ophthalmologist will read it to just make sure that it was all done right. And for $40, you get a prescription. And if you want to spend a modest amount, I think it's something under $100, they'll mail you a pair of glasses. But in the state of Georgia, they just made it illegal under pressure from the optometrists. This is a friend of mine, Ian Tong, Chief Medical Officer for Doctor on Demand. I have used their service when my own doctor was away for a 3 or 4 day long weekend. I had a sinus infection. I didn't want to wait, and I certainly did not want to go to an ER. And within almost always within 90 seconds, you go on your iPad, click, there's a doctor looking at you, just as Ian is there. And the doctor said, open your mouth, put it over the camera, say, ah, whatever. And she examined and said, okay, I can see what you got. And in 10 minutes, there was a prescription waiting down the corner from me. She was in another state. California company, New York doctor, Virginia patient. However, in some places, including this one, they're fighting tooth and nail to stop this. So in Texas, the state medical board has issued regulations that would essentially say, well, you can do telemed, but only if you have personally gone and, I don't know, shaken hands with the doctor somewhere or been examined. So if you, as I understand it, if you've been checked for athlete's foot 5 years ago, you can have your sinus checked by this. And I'm writing an 18-part series. I've got on the last slide, it'll have the URL where you can find it. It's on the Mercatus website. I'm writing about all of these things. And I'm writing about Doctor on Demand, and I had Ian explain to a group of legislators from across the country how he saved a woman's life using their app, who probably would have died had she gone through her usual path of waiting till the next day, calling the doctor, making an appointment, etc. This is a matter of life and death. I've also written how through a bit of amateur telemed, my mother's life was extended by 1 year from 92 to 93 because my nephew, who's an ER doc, looked at her through Skype or FaceTime, saw her discoloration and her breathing, whatever, thought she was going into sepsis, said, I can tell it because my poor mother is now dearly departed. He said, Grandma, you want to show me the wound? It was down here, and she said, I'm 92, what do I care? So she took her iPad, showed him the wound, and he called my brother, who's a doctor, and said, get her to the hospital. I think she's going septic. And she was. She probably would have died had it not been for a little in-the-family amateur telemed. I don't have to talk to you about Keith's thing. Keith told you well today about his transparent pricing and the obstacles that he faces. This is the Narayana Health Hospital in the Cayman Islands. Arguably the best cardiology hospitals in the world today are the Narayana system in India. You can read about Devi Shetty's work, it's legendary. I've met people who've been to the hospital, and it's apparently astounding. So they wanted to build a hospital for the American market where you could get lower cost, probably higher quality cardiac surgery, cardiac care. And they built it in the Caymans. Why? Because it's out of reach of the American regulators. It's close enough that you can get down there. It's a short hop from Miami. But again, can you spend your Medicare dollars there or your Blue Cross dollars? Probably not. I teach at a couple of universities. My students are mid-career professionals, doctors, nurses, administrators, just like everyone in this room. And they have all sorts of fears of why, well, do you really want to go out of the country? And I can pretty well shoot down any of them. And I'm writing, one of my articles will be on Ruchika Fernandopulle. And I don't have to tell you about DPC, the virtues it brings to the market. I don't have to tell you about the obstacles that insurance commissioners and others bring against it. So I'm on Twitter a lot, and one of my friends on Twitter who's in a DPC practice, I don't know if he's here. I meant to look to see if he's on the list. But he wrote an article, Why There Will Never Be an Uber of Healthcare. And I wrote to him and said, do you mind if I use your good name? Because I'm going to write an article that says why there are going to be many Ubers of healthcare. And his article it was a good article. I disagreed with it. It said that getting a ride is a transaction, medicine is a relationship. That it's your PCP, your gatekeeper there who really holds the key to your life. And that, I hope I'm not misinterpreting, but you can read both articles. And he said, Uber's about ease and convenience. And I said, no, Uber is way more than that. Uber is about safety. Uber is that when your daughter is trying to hail a ride at 2 in the morning in a dangerous neighborhood, she can be pretty well assured of getting a ride and of knowing before the ride gets there what the driver looks like, what the license plate is, what the number is, and if there's a thunderstorm going on, she's a lot less likely to be hit by lightning for a long wait for a standard cab. I said, first of all, I agree that the relationship in today's medicine is a pretty important thing. I'm not sure it's as important as most doctors do, but I'm willing to say fine. We can talk about that. But I would be much happier in a world where the personal relationship with my PCP is not as important, where I can walk into an ER in California and somehow give that doctor access to my electronic medical record, electronic health record, and that doctor can quickly get up to speed on who I am and what my needs are. And I won't go on too much longer on it because I want to make sure I get through everything I have to say, but my articles on it are there and you can see the full discussion of it. So how do we turn, what we really want to do is to take the routine parts of medicine, even parts we never thought were routine, but we realize they are now, and commoditize them. To take as much as you can about the doctor-patient relationship and turn it into the repetitive tasks into a commodity that you can computerize, and leave the doctor for the high-level functions that you cannot automate, so that you folks, instead of being typists, will actually be doctors and doing serious cognitive work, which current practice is keeping you away from. So this is my upcoming research effort, and this is kind of the key to tonight. So people talk about electronic health records or medical records, and I've even heard people talk about smart EHRs. I don't want smart ones, I want brilliant ones. I want ones that really take the rote tasks away from the doctor and put it into this to make it much more of a transaction so that I'm not dependent on my doctor who may move away or die or be on vacation or I might be on the road. So what I want, and I'll just very quickly give you my idea of what it ought to look like. where we ought to be going. And I'll start by saying I've spent my whole career being an outsider, coming in and giving opinions on things that I don't know anything about. I'm not a technologist, I'm not a programmer. And I was hired 30-some years ago to be a specialist for Chase Manhattan Bank on sub-Saharan Africa. And I was hired because I had no experience in sub-Saharan Africa, and the guy who hired me was sick to death of everyone who did. He wanted an outsider's opinion to take a fresh look. And that's what I'm doing here. And I will invite you as I talk, if you think that what I'm saying is interesting or wrong, or you have some suggestion, or you say, oh, what you're talking about we're already doing, I want to hear about it. So again, my email address is there. So what I imagine is an EHR that doesn't belong to my PCP, belongs to me. So I've got Bob's EHR. And on the left you see it's got data flowing in from my primary care doc, the emergency room, my Fitbit, my musings. If I want to say, I'm not sure I ever told the doctor that my father developed macular degeneration at about age 80, and that probably ought to be in the record, bang. So I can feed into my own EHR. My AliveCore, the EKGs. When I go to the pharmacy, when I go to doctor-on-demand telemedicine, when I go to my gastroenterologist, I want it all going into one place. And so what I've pictured here is a chronological record of every entry that's been put in there, unordered. And then I'd like fierce competition among, you can call them browsers, and you call it an EHR browser, reader. I want Google doing it. I want Apple doing it. I want Microsoft doing it. I want companies I've never heard of. Someone in the audience saying, I know how to do it better. I want fighting. And importantly, I don't think the skills and the qualities that make for a good input side are the same skills and qualities that make for good output. There are a lot of different products that are feeding information right now into the internet. All different computers, cell phones, tablets, using different programs, different data sets. The one thing that the federal government did very well was they developed an excellent protocol that allowed all these machines and all these data types to feed into the EHRs, into the internet. And interestingly, the government didn't say anyone had to use it. There was no mandate. It was, here's a protocol. The Defense Department's been using it. You want to use it, use it. If you don't, don't. And it became the standard. And there are other challenges coming up to that standard, but for 25 years, it changed the world. And on the reader side, if you think about the internet, the people I feed the information into the internet with when I do my website, that's not how I read it. I read it on a browser. It might be an Internet Explorer browser. It might be Firefox. It might be who knows what. And I use different search engines. And I can imagine a Google EHR reader that my cardiologist uses that sucks all the relevant information using artificial intelligence, sucks all the data points that the cardiologist needs and leaves the rest and organizes it and puts it into a form that a cardiologist I've never met before can look over it in a couple of minutes and get a very good idea of who I am and what I'm about. On the other hand, if I have a sinus infection, I can go to the doc in the box and it'll give a few little data. It isn't going to tell them that I had a broken toe. It might not tell them this or that. It doesn't have to give them my Fitbit information, just what's relevant. And the technology is already there to do this. And I even want I want my own reader. I want something that puts it into a form that I can read and adjust. I just had a small situation. My primary care doctor has got a pretty forward practice. I can go on and read really quite a bit of data on myself on her portal. I can look at my recent results, my lab panels and what have you. And I noticed it said that I suffered an allergic reaction to penicillin in 2014. So I typed a message and said, yeah, actually, it was in 1958. It might be relevant if you need to treat me for something to know that I didn't have this 2 years ago. I had it, I don't even want to do the math. I don't know. But, so I want to be able to feed it in. I want it to put it into a form that's organized, not a big mishmash of things in chronological order, as they tend to be present. This was the original internet browser. This was OliWeb. It came out in, I think, 1993. What do you notice about it? It kind of looks like a small aircraft panel, dashboard. You put in your search term. It asks you, well, do you want to look at the URL? Do you want to look at the text? What kind of records would you like to search? What kind of fields do you want? Check all these boxes. You can restrict the results to this, say, okay, stop after how many matches? It was an amazing invention for its time. But now we have this. And it's completely replaced it. Why are there no check boxes? Because Google knows which boxes you would check better than you know. Google has spent a fortune to figure out how to read your mind and to do this simply so that you don't have to fill in the check boxes. And when you see this, I want you to be thinking of the check boxes that drive you nuts on an EHR. And I also will note the cute little top and the Google Doodle at the top. Google didn't do that because they just felt like putting cute pictures. They put it there because it attracts people, because there's something kind of entertaining about going on Google. And I imagine that in the future, there will be a certain entertainment value in a doctor going to an EHR, which there certainly is not now. I can give you one example where there was. A doctor, kind of a quirky emergency room doctor at George Washington University, wanted to develop a database of what actually works in ER. How should you do triage optimally? When a patient is presenting with certain symptoms, what do you actually want to do? Because up to that time, it had been almost entirely intuition. Nice intuition, but not really very studied. He needed a lot of data, and he needed his colleagues to be entering lots of information on their patients and what happened. And he knew his colleagues, the last thing in the world they wanted to do was enter data for him. So he did the equivalent of a Google Doodle. He knew, I've got to make them want to do this. His approach was he put a sign on it saying, do not touch. And all of his colleagues said, I'm going to touch. And they started, and he had built it so it was sort of interesting. And, oh, okay, well, this actually, I'm learning a little something as I'm entering the data. And before they figured out that they were being used, he had built essentially an ultimate ER database, which became one of the industry standards and became a commercial package for ERs. If you picture the way we're doing EHRs now, it is as if the federal government in 1993 had said, search engines are the future. They're going to change the world. They're very important. Once people are using search engines, life will be better on planet Earth. So we're going to declare OliWeb the official search engine of the United States government, and we're going to give OliWeb $40 billion to add more checkboxes to it. And honest to God, I think that's where we would be today. We would never have gotten the revolution that all of us are carrying in our pocket. What happened was Google was the 21st search engine to come onto the market. Over those years, from over about a 5 to 6 year period, you had a succession of Alta Vista and Hotbot and Yahoo and others, and they all improved in different ways. Some of them made them graphically easy. OliWeb, as nice as it is, it would be a lot improved with better fonts. It's not a trivial issue. If your eyes are staring at ugly fonts, you get tired of looking at the thing. And so there's been a lot of effort put into figuring how can this thing be inobtrusive, kind of entertaining, informative, and when the person finishes with it, they feel I've actually gotten something out of this experience. And of course, at the bottom of it is EHRs today are primarily for reimbursement purpose and very little for therapeutic purpose. And I think that will change. But I think you're going to ultimately have to go to something like Congress did 25 years ago. Stop mandating and stop subsidizing picking winners. You know, getting people like me in Washington who have no business picking winners in this sort of realm doing so, and let the market fight. Just one other little product. How many of you are familiar with Augmetics? See, you ought to be. Yeah, I see a couple of hands. This is Ian Shakil. I've got an article coming out on him in about 2 weeks, 3 weeks. That's Google Glass. Ian developed this system, company out in San Francisco, that when doctor is interviewing a patient, examining a patient comes in and they're asked, the doctor plans to wear Google Glass and live stream your exam to the back office. Are you okay with that? And interesting question. I thought an awful lot of people would say, no, that's kind of creepy. I don't want to be live streamed while the doctor's talking to me and examining. Then I asked him, how many people say no? And he said, a couple percent. Most people say, fine, I don't care. Anyway, what happens is the doctor's got no computer, no tablet, no nothing. The doctor is talking to the patient, looking the patient in the eye, doing all of the touch and whatever that a doctor has to do. Meanwhile, it's being live streamed, audio and video, to a back office which is assembling an EHR in real time. By the time the exam is done, the EHR is done. If the patient wants to walk out with it, the doctor pushes a button. Here you are, sir. It's all finished. And their early estimates, and it's in beta testing, some hospitals are using it, it cuts out basically about 35% of the doctor's work week. So the doctor can take 35% more patients, or spend 35% more with each patient on average, or play a lot more golf. And again, this is just dividing up the work of a doctor, taking away the rote, annoying things that you hate to do, and splitting it up in a way that was not possible before. And it'll be interesting to see what the regulations do, what HIPAA does with it. It is HIPAA compliant. Not that I'm a huge fan there of HIPAA. But anyway, it's these are the innovations I think that are going to change medicine, that are going to change the way. It's going to put more power into the patient. I cannot tell you how empowered I feel having that little device on my phone, how much peace of mind it has brought me in the last 6 months. I cannot tell you how much it has kept me from calling with annoying phone calls to my PCP or my cardiologist to say, this happened, is there any problem here? Do I need to be worried about this? And increasingly, we're going to be taking charge of our own health. You as doctors will be able to do much more of what you actually wanted to do in medicine, as long as we allow it to happen. In the last 2 slides, if you want to read more about this stuff, here are 10 books I would recommend, including David Goldhill's book. But these are some others that will give you a very different view. Over here is Bronson Smith, who is a former student of mine. He's been subjected to some of these books in my class 3 or 4 years ago. And these are some of my writings on these subjects, including at the top one is the 18-part series. And with that, I don't know, let's go to some questions. Thank you. Questions, spitballs, you name it. Anything goes.
So if you had to predict something big in medicine, what do you see the next big thing coming from, or what do you think it is?
Big thing. See, I think it's a ton of small things.
Okay.
I tend to think it is, I've shown you a huge number of these little innovations. I think if you want a big trend, we have some huge things going now: 3D printing, nanotechnology, wearable telemetry. I don't know, I could name a few more.
Specialized medical care, the
Right.
immunotherapy.
Right. And they are converging, slowed down somewhat by the fact that we have institutional obstacles, government, regulation, laws, and, by the way, the intransigence of kind of old school medical professionals who don't want things to happen. There are a lot there. You can point blame in a lot of places. But these things are coming together. As one of the books I had was Eric Topol, The Patient Will See You Now, who argues that this device will very likely prove to be the most important medical device in human history. My little EKG reader is just one thing. There are a vast number of apps, and we are at a very, very early stage. And I would, okay, here's a big trend that will sum up what I'm saying. Historically, medical science has been largely a sort of a branch of biology, of biological science. In the 21st century, I think it will be as much a branch of information science as it is biological science. It is our ability to capture data we had never imagined before and torturing it and twisting it and reading, squeezing information out of it that will very likely do more to improve our health than the drugs, the devices that we do. How's that one?
I just took a picture of that on my i7.
Terrific, terrific. What else? Well, in part that's a political question. If you wanted fast action, the states actually have considerably more power right now than the federal government. Yes, people in Washington want to talk about the Affordable Care Act and whether to repeal, whether to change, whatever. It's going to be a big struggle, and who knows how it'll turn out. But right now, state legislatures and governors can get rid of certificate of need laws. They can open up to physician extenders like nurse practitioners or nurse anesthetists. They can eliminate corporate practice of medicine doctrine, which was a strange, progressive era, essentially anti-capitalist piece of legislation, which somehow a lot of people, regardless of politics, have absorbed as, well, that must be a good idea because we've been doing it for a long time. There are all sorts of things at the state level that could make a huge difference now, and the states tend to be saying, I want them to fix Obamacare, and it's fix your own house right now. Now, I argue in Fortress and Frontier, actually, that there's a chapter in which I say that there were two approaches in the Pacific War in World War II. There was one where you sent the fleet en masse, or you can look at the European theater where we're going to establish a line and push and push and push. And then there was the strategy that was used in the Pacific called island hopping, which is we're going to do one little thing, we're going to capture this island, and once we secure it, we're going to look around and find another vulnerable island and do that one. And we're going to keep doing that until we own the whole ocean. And I think when you ask, I don't know of any one thing you could do that would change the world. I think it is going to be, we're suffering from death by 1,000 cuts. You got to start stanching the bleeding in all 1,000, and you have to find the ones that are easiest to start with and move one by one.
Before that actually takes place.
Yeah, I mean, the opening of the internet was an interesting one. At first, there was a bipartisan consensus that said, let's establish a big regulatory framework to control the thing. And it was on the verge of sailing through Congress. No one really was thinking twice. We regulate everything, why not regulate the internet? Technology community and others started saying, hold on a second, you're about to kill everything that's about to happen. And they started picking off Democrats and Republicans who eventually swarmed over to the side of, let's open the thing. And as I was saying here, when I talk to a lot of conservative groups, I talk to some liberal groups. When I talk to the liberal groups, I love to say, and by the way, yes, indeed, Al Gore had a big role in opening up the internet. He may have spoken injudiciously about it, wording, but in fact, he was one of the movers and shakers in that. And it truly did open the world. But it was not a foreordained thing. It was, in fact, going exactly the opposite direction. So there are, let's see, and I'll see if I can remember all 5. I usually list, there are 5 big things that, I'm getting back to what would I change. So the single biggest problem in American healthcare, and the single most troublesome, is the Medicare pricing methodology, which, and I've got a piece coming out on that. Maybe I'd already, no, I think I already mentioned it. I think it's in writing already, saying that without being ideological or exaggerating, Medicare is basically Soviet-style pricing. It corrupts everything. We call our insurance private insurance, but basically it's Medicare with a few tweaks. So you're going to have to do Medicare. If you don't do that, you're never going to get this. Medicare is driving EHRs. Medicare is driving all sorts of things in the wrong directions. Secondly, the FDA. You can look, and I've written, some of my articles have this. The European Union, which I'm not a huge fan of, has a much better drug and device approval system than we do. It's competitive, it's private sector, it moves faster, it moves cheaper. And it's one place we ought to start looking. I've mentioned all the state regulations. Hospitals, that's been talked about a lot here. Hospitals are sacrosanct. Well, that hospital's been around here since my granddaddy's days, and it's the biggest employer in town, so no, we don't want someone else coming into town with a better hospital. And the 5th one, which I think is really critical, and some of my colleagues, I've been talking it up in Fortress and Frontier and elsewhere, and I think we're going to end up doing some research on it. The whole structure of medical education is a 1910 model. That is, if you look into the history of it, it was absolute progressive era, centralized command and control. Every medical school ought to have an identical curriculum. Every student who comes to a medical school should have the same background. You should do 2 years of lab and then 2 years of practicum, whatever. And what we have done is we have robbed it of the variety that could exist and that does exist elsewhere in the world. The Caribbean schools, which started off as sort of low on the totem pole decades ago, are actually making some significant strides in alternative curriculum models. And we are getting a few here. Harvard just changed its curriculum last year as one of the final acts of Jeff Flyer, its dean. And I recently met the director of one of the first, well, I think it is the first dual program in medicine and design at Jefferson in Philadelphia. So if you want to go there and become a doctor and design medical devices, you do your training in a dual manner between the two. So I think those are the big ones.
It's really going to be where the technology leads.
It's a great point, and I actually quite agree with you. And think of it this way. What these technologies are doing they are eliminating 2 things that are the demon. I've just written a paper, it's not out yet, co-authored with Eric Topol, whom some of you may have read, on the history of paternalism in medicine. And 2 things from the time of Hippocrates till now have really driven paternalism, which is fixed costs and learning curves. Heretofore, it has been a very expensive procedure for, let's say, a primary care physician to actually get to know who you are and what your physiology is and what your mentality is, what your needs are. There's a big learning curve, and it's expensive to do it. So when you shift doctors, that doctor is rock bottom and has to rebuild that process. What I'm talking about is a way of squeezing down, reducing the fixed costs and the learning curves so that, yes, if I move from Alexandria, Virginia to wherever it is you live and I want you as my doctor, bang, I can bring you up to speed. And I'll give you just an analogy. A couple months ago, I got picked up by an Uber in Washington. And I always talk to the drivers. They're kind of interesting stories. So this was a young kid. And I said, which part of town do you live in? He said, I live in Chicago. I said, well, this is Washington, so what are you doing here? He said, my parents live here, and I'm visiting them this week. And they're out today, and I didn't feel like sitting around their apartment, so I figured I'll just go make some money. And so he said, I just turned on the device, and I'm driving. What that means is he didn't have to go through the process of learning how to navigate around Washington, which is a tough place to navigate. And suddenly he and I could have a very personal relationship. He could get me where I wanted without any problems. And I think the same thing will ultimately happen with these technologies that will make it possible for you, bang, to be up to speed on my needs really quickly, as opposed to the old way where it's going to take you years of really getting to know doctor and patient. So yeah, I think there's complete consistency between being more personal and yet in some way less dependent. Don't bite tongue. We love that. We live on controversy. I'll halfway disagree and halfway agree. I don't want to be an automaton in it. No, I don't. I think the doctor has a legitimate use, and I think what you're going to find, even the people in this room are going to find, that a sizable percentage of what you do in life is rote routine that distracts you from the cognitive brilliance that you carry in your brains. You're typing on charts, you're filling out things, you're spending it on the rote, and what we have is the opportunity to take those rote tasks and let you do what cannot be automated. We've seen this in other fields. This was the whole course from the Industrial Revolution on, fields where people thought you cannot automate this, it's a very personal task. We found ways to do it. I want to unleash you, and I want you to be able to be personal, but without the struggle of getting up to speed and acquiring information and maintaining the information in your head. We are a very mobile society now. People move, people travel. I'm on the road a lot. I might get sick somewhere else. I would like the doctor that I see when I get sick on the road to be in a lot better shape to look at me than they would be normally. I adore my primary care physician. She's very important to me. She knows me, and I don't ever want that to change. But actually, we have lots of discussions on this, and she's in a very forward practice that, again, shares the electronic health record, at least a portion of it, with patients, and I can contribute to it, and I can discuss it, and I think it's going to be much more of a back and forth process between patients and providers. Some of the speakers were referring to that earlier. So I don't come in and say, your whole world is gone, it's going to go away, but I do think it's going to change significantly. And I think it's going to change significantly for the better as long as we allow it to. Also, I have no problem with people, as you said, deciding what sort of practice do I want to go to. Do I want an intensely personal one with direct primary care or some other model? I think that's great. What we have now is a forced homogeneity, largely from the federal government, but also from the state governments, to say, we're going to set the standards that patients and providers have to live with, and that means you've got to fill in these forms, you've got to do meaningful use, you've got to use the kind of EHRs that we want. I would love to let all sorts of models flourish. I happen to be a big fan of that, of yours, which is why I'm here. But I do want to see competition between different schools of thought, and I'd like to see them tweaked and progress and not stay in a sort of a stasis, as to a large extent, a lot of medical practice and medical training has been since the Flexner Report of 1910. I'd like to let you have more leeway, not less.
Thank you. And with that,
Thanks.
I really want to thank Dr. Graboyes for coming and spending the time with us. He's been with us for a couple days now, and I really appreciate his insights. You know, one of the important things about conferences like this is not necessarily to stand up here and have an echo chamber of people telling us things that we like and agree with. It's to share ideas, to inspire thoughts, to encourage thoughtful debate. And so it's always nice to hear different perspectives on things. So I really appreciate the thoughtful questions we've had throughout the entire day today. Again, I appreciate Dr. Graboyes coming out. Thank you, everybody, for a wonderful day. We will see you all tomorrow morning. And I believe Dr. Graboyes will be more than happy to entertain a couple questions here at the front.
Sure, I'll be
Thank
there,
you.
or if we can go out to Zach's reception. And I'll just say as a last thing, you'll have this, you'll have my email, and you or anyone else, please write with criticisms and compliments and ideas and suggestions. I'm co-authoring this with a physician who's one of the most humane OBGs I've ever met. And let's see where it goes, but I do want your input.